questions, may I ask Dr. Acuña and Dr. Palabrica to come and join us in front as we entertain questions from the audience. Questions from the audience.
The indications for treatment are either pain or neurologic deficit. Uh, can you give us some pointers of whether you can do minimally invasive surgery, one level, you can do short level fusion, and you can go all the way and correct the deformity? How do you decide on what kind of procedure do you have? That's for both of you.
Yes, sir. Well, that guide that I have been using has been very helpful. It still boils down to the physical examination. So when your physical examination just simply reveals, some numbness, but he can still significantly walk quite far. I would just simply do the compression. The thing with ASD or degenerative diseases of the spine, they put the spine also in some kind of stability, because of the hibernated or hibernation of these structures of the facet joints. It can put that segment also in a relatively stable form, except that it compresses the spine in effect. So when you're able, with physical examination, and you can somehow confirm it with that, and if you think that the radiculopathy can be addressed with simple decompression, then I'd rather just simply indicate that patient for just simple decompression, sir.
When do you go all the way?
When do you what? Well, again, still on the physical examination. The usual all the way. Oh, si ano na? Si Dave na. When do I go all the way? When you say all the way, you mean correct the deformity, the compress. When all this constellation of symptoms of ASDs are really, you put it in a severe part, and also looking at those parameters, you have to correlate them with those parameters. Then that's the time. That's the time that I'm going to go all the way. Dave.
All the way. Si Dave lang nag-go all the way. Looking at all the points to consider, like the SWAB classification, the one that was mentioned by Dr. Palabrica. So what matters most is the primary symptom of the patient. Is it neurologic or primarily back pain? So if for most of the patients that I see in the clinic would presents the symptomatic cases are more of the thoracolumbar spine, and not all of them would present weakness, but more of neurogenic claudication, and some would present radiculopathy. So for radiculopathy and no instability cases, I think decompression is indicated for cases like that. But you have to look for some instability and the degree of scoliosis, and of course the cost consideration. Yeah. So, yes, sir. For cases with instability, most of the patients would present with lateral listhesis, and you have to do decompression and instrumented fusion. I have few cases that I always, I have done not more than 10, from T10 to iliac, to correct the scoliosis and the lordosis, and the kyphosis as well. So nowadays we have a new technology, not relatively new to us, a relative new technology that is promising. It's minimally invasive deformity correction by using your X-lift or O-lift. No, you don't have to undergo to do osteotomies. You can correct your deformity by correcting your anterior column. It's less bloody, but of course it's more expensive. I'm still waiting for my first case for that. Previously my previous experience is I do a lot of Smith-Peterson osteotomies, at least 3 to 5 levels. If I do osteotomy, I make sure I have a 3-rod technique. I use 3 rods. Almost all the companies has connectors nowadays, so that makes them wealthier again. So please, that's the recommendation now in the adult spine deformity group to avoid pseudoarthrosis and rod breakages. So they recommend 3 or 4 rods, or even 5 or 6 rods, to avoid those complications. There's a good paper by Lenky. Maybe you can review that. Yeah. So osteotomies, if you do correction, you should make sure you should do osteotomies. And a tip for correcting scoliosis in adult, I don't do the rotation. It's more of cantilever technique, because if you derotate, your screws will pull out. And if you want to have more deformity correction, use your L-bend or inside the benders. I won't suggest derotation.
What are your indications for extending down to the pelvis?
If I have, yeah, that's a very good question. It's, extending the pelvis is extending your pocket. It's times 2 the implant cost. So I extend my to iliac if ano ba indication ko din? Yeah, when I usually look at the sacral slope. If the sacral slope is very low, I need to correct that sacral slope to a more acceptable level. Yeah, the pelvic tilt and the sacral slope goes together. If you correct the sacral slope, you will correct also the lumbar lordosis. So, yeah, if you don't extend your fixation to the iliac or iliac, you won't be able to correct those pelvic sagittal parameters.
Yeah. I agree with no, Dr. Larry, but also in my in the presentation that I did, when you correct if your sacrum is actually when it comes to the bone stock, it's still good, then you may opt to free the iliac. But in the event that but it is very specifically recommended that you have to make those screws purchased bicortical, so towards the sacrum, towards the sacral promontory. Now, in the event where there is really bad or not good bone stock, you might have to especially if you have more than 3 levels of fixation of instrumentation, you might have to do sacroiliac fixation in order to limit dissociation also of that area. Para isa na lang siya when you try to correct the deformity.
Thank you.
Yes. For, let's say you want to end at L5, but you have a block disc at L5S1, is that a consideration? Would let's say you have a long fusion, you want to end at L5, but you said that at L5S1, if the disc is not good, then include S1. But how about just a block disc?
Well, I haven't thought of that, really. I think it's still safe to, for me, it would be still safe to include the S1, for that matter. We don't also, probably the facets may also have been affected. So if there is any pathology in the area, even in the level of the facet joints, that is in itself is a recommendation of spanning through that area is the recommendation.
Sometimes it depends on the apex and the planned end vertebra that you're going to screw, or your end vertebra. The L5S1 has been a very controversial topic even nowadays, no? And I think there's no answer yet. And there's such thing as adjacent segment disease, or if you extend to S1, there's a high incidence of pseudoarthrosis. So I think to answer this problem, I think nowadays more and more surgeons are doing A-lift and X-lift on the anterior. More and more, because if you do open surgeries for anterior, so it takes a long time. But we have technologies now that for X-lift and O-lift, for one level, you can do it 30 minutes to 45 minutes per level. And but the only drawback is expensive. At least there's something we can offer to our patients nowadays. Yeah. So, yeah, now there's increasing number of patients consulting adult spine deformity. So we expect more failures in the next 5 years.
Thank you for that wonderful discussion, sir. Okay. So thank you, Dr. Cunha, Dr. Palabrica, and Dr. Jose online. Okay.